Goes on to say institutions become self-congratulatory for moving beyond so-called biomedical models, for emphasizing function or relief, and for reducing reliance on medications deemed politically and morally dangerous. Yeah, and I've called that out before. Man, it's like a badge of honor. Institutions, doctors that work for institutions, again, nothing against these folks. They're good people. They mean well. They're highly educated and they treat their patients well. Okay, I'm not calling them out for that. But there is a culture in these bigger institutions that elevate their existence above opioids, almost as if they've never needed them themselves. Welcome to another episode of the Dr. Dustin Show. So I came across this article and I just wanted to talk about it on the show because I feel like it is such an important article to bring to light so much of what we've been talking about on this show. And I think this will go towards the conversations I've had with Keith and the Invisible No More crew and really help everybody get a sort of backdoor acknowledgement, if you will, of what's going on in the pain community, specifically as it relates to the prescription of opioid medication. So this article I found on kevinmd.com, and it is written by Joshua Saylor, who identifies himself as a healthcare writer. The title is "The Double Standard at the Heart of Chronic Pain Treatment." And, immediately I'm like, oh, I do chronic pain treatment. What is the double standard that I am doing? And actually, the introduction was quite eye-opening. And it plays on this idea of addiction and chronic pain, how we treat addiction differently than we do chronic pain. For example, addiction we understand to be a neurobiological process that affects neurons and brain chemicals, and we really try to remove, to a reasonable extent, the patient's decision-making capacity and the morality of the condition from the condition itself, right? It's a disease process that often gets people unsuspectingly, and it's not always something that we can control as patients. And so the treatment then becomes, in most cases, a medicinal long-term treatment, such as with buprenorphine or with methadone, and sort of this long-term opioid replacement therapy under, of course, controlled conditions can result in probably the best outcome for most patients. Certainly that is true, let's say, compared to more behavioral interventions, psychological interventions, or even inpatient rehab. While those things may work for some people, and I'm not discouraging them at large, the relapse rates are pretty high for those treatments alone. Now, the relapse rates are high for medication management as well, but not nearly as high. And so that tends to be the approach. It's not highly stigmatized. It's at least in the medical community, it's well established, and that's the approach that we take. But for some reason, when we're talking about pain management, even though we can acknowledge that there are very standardized neurological pathways, there's still brain chemicals involved, there's neurosensitivity, hypersensitivity, neuroplasticity, all of these biological mechanisms that go into play. We tend to get a little bit hands-off when it comes to the application of the same approach in treatment. Right? Now it's you need to go do your behavioral treatments. Now you need to go do all your exercise and basically do everything but medication management, in this case specifically opioids. And so that really is the double standard that is at the heart of this article. And I want to get into a few things here because he brings up some very salient points. Some things I agree with, some things I would perhaps argue back with. So going into this article here on the first page, I've highlighted the things I want to talk about. The double standard, I'm reading from the second paragraph, the double standard in question cannot be dismissed as a minor inconsistency in clinical emphasis or application, but it reflects a deeper conceptual and philosophical confusion at the foundation of modern pain care. Now, if we take a step back for a minute, this is why I love pain so much, because I think the concept of pain transcends many different borders, many different definitions, many different cultures and times, right? So from my perspective, I tend to look at it through a biblical perspective, right? Going back to the fall of Adam and Eve and the origin of sin, right? Pain was really one of the first things that came into humanity at that point as a consequence of stepping away from God in that instance. And so, I think ever since then, I always wonder, well, in the Garden of Eden, did we have pain, right? I mean, because we can talk about pain being a protective sensation as well, of course. And so, what if Adam was climbing a tree and he fell out and broke a bone? Would that hurt? Well, the question, of course, is, would he have broken a bone? And, maybe he felt pain through nociceptive pathways, but was it severe enough and long enough to translate into what we would call suffering? These are questions that I don't necessarily have answers for. But certainly after the fall and our experience ever since, we can understand pain to be really more than just nociception. But there's social pain, there's spiritual pain, there's emotional pain, right? We're very complex creatures. So to really define pain in a very narrow capacity is quite challenging. And I do think that is one of our jobs as physicians who treat complex human beings, is to really identify what it is that we're dealing with. I mean, yes, we all have bodies that are failing. We all have bodies that are painful, really, to some extent for everybody, right? And, unfortunately, some people have that much more severe than others. But that's not to say that, it can't be multiple things or overlap of things, or how we interpret pain or experience pain, or the meaning we identify with the pain, the purpose of it all, right? So all of that plays a significant role in how we can recover from pain itself. So for the purposes of this discussion, I'll narrow the definition of pain to really nociceptive sensations that kind of get out of whack and last for too long, right? So sticking strictly physiologically speaking. Okay. So again, if we're going to understand addiction in a strictly physiologic manner, then how come we don't treat pain also as under that same understanding? Instead, Joshua notes here, pain is quietly moved into a separate and now morally charged category, one in which medication is approached less as a therapeutic tool than as a reputational and political liability. Now, I was saying this just the other day, actually. If you caught my show last week, I was responding to another pain physician interpretation on why pain doctors don't write meds. And his approach to this was that it just doesn't pay. All the money's going to procedures, and that's why your doctor's not writing meds. And I politely disagreed with that, and I tried to illustrate through the numbers that actually there's quite a bit more money to be made in prescribing than in doing procedures. And the reason why I gave in that episode was because physicians have stigma too. Just like patients have stigma, physicians have stigma too, and we have to defend ourselves to the state, to the feds, to other colleagues, other hospitals, other clinics, our referring sources, other patients, and the patients' families who may not understand the whole concept of what it is that we do or why it is that we're doing it. And so there's absolutely a reputational and political liability that goes along with prescribing opioids. And for a lot of pain doctors, it's just not worth it, right? Maybe they don't feel super comfortable with the concept of writing prescriptions, or either from a practice standpoint or a knowledge base standpoint or experience. Maybe they work in a clinic that generally poo-poos the idea of long-term opioid therapy. Could be a lot of different reasons, but it does boil down to what I think to be the primary reason, which is the reputational and political liability. A close second to that, of course, would be patient safety, outcomes, things of this nature. But as far as money goes, no, it's way down the line. We're not pushing procedures, at least in my experience, to make any kind of real money. Let's put it that way. So yes, the consequence of this shift is that pain patients are not merely being treated differently. They are being subjected to a different ontology and epistemology of suffering itself. So again, it just feeds into the stigma of being a pain patient, really. And we've heard a lot of stories, unfortunately, from perhaps viewers like you who do experience, I would call it injustice, right, in this way, in the medical community, and ultimately patient abandonment in a lot of cases too. And this article does bring that up. So pain is not reducible to narrative, coping style, or a psychological interpretation layered over neutral sensation. It is a real neurobiological phenomenon. And I think that's really important to say, because again, it's the recognition that we are complex humans. There's a lot going on. And to narrow it into, well, it's, all in your head, so to speak. Well, if you can't just tough it out, come on, you can tough it out. Just hold your breath, right? If it hurts, don't do it. I mean, how many, sayings have come about throughout the years that, pain patients, I think, are often, those sayings are often directed at. Again, it's not just that simple. If we're going to recognize addiction as being a neurobiological process, or depression as a chemical imbalance has been the go-to phrase for that, why are we not recognizing pain as being a neurobiological phenomenon as it relates to medication prescribing, right? And there are some reasons, like I said, I think there's reasons on both sides of the fence, and we'll get into that, but this is what the point is he's trying to make here. In contemporary pain care, multimodal language too often functions as euphemisms for pharmacologic exclusion, right? That kind of hit me. As someone who practices multidisciplinary and interdisciplinary care, which is the scientific gold standard, it was interesting to see sort of the negative perspective on that, right? And again, I think that's because so often these other treatments are used to the exclusion of prescribing. And a couple things there, we never want to jump out of the gate with the most strong, respiratory depressing type medication to give to our patients. And I realize that if you're in pain, you want to be out of pain as quick as possible. Certainly that's true for acute pain. Not to say it's not true for chronic pain, but you've kind of been there for a while, and so you've learned to cope with it to some extent. I think that gives us a little bit of time to find a solution that is not going to put you in a coma right away, that can build, some progress over time and get you to the goals that you want. I don't think there's anything wrong with taking a conservative approach there. And I know probably a lot of patients would agree with that. I actually hear a lot of times patients, they'll come in and be like, well, now you're not just going to give me meds, right? Because I read about, this peptide, or I read about, this exercise, or this, you said you had laser, right? What about that? Can we try those things first? And I think that's a very healthy approach to treat really anything. Just in the same way we would approach weight loss, or same way we would approach diabetes or high blood pressure. We're not going to try to bottom your blood pressure out day one, right? We're going to chip away at it in a way that is sustainable. So, but the problem with this, I think in a lot of cases, is that yes, there are clinics and physicians, and I know patient experiences after hearing from you, where It's like, well, we're going to do literally everything but. It's like, okay, well, then you're not really about treating pain, right? And the same thing is true, I think I would apply to patients as I would doctors, right? So if a patient comes in and they're like, I really want this drug, okay? We've talked about doctor shopping or doctor interviewing and that type of thing. Well, okay, I understand, you might want that drug. Maybe you've already gone through the whole rigmarole and that's where you ended up and that's where you want to, establish a relationship with a new physician. I understand that. That will take a lot of conversation and record review to get to that point, but okay. But if all you are interested, like if you're starting from ground zero and you're like, hey, I really want this medication. Well, okay, I understand that. Maybe we could try these things first because, there's maybe better evidence behind it. It might be a little bit safer or more sustainable. And you decline that. And you're like, no, I just want that medication. Okay. Then the perception on my end is that you're really not about pain relief. You're really just about that medication, which of course is a red flag. It might lead to a breakdown in that relationship. Well, the same thing I would put on physicians, right? If you call yourself a pain doctor and you've refused to write opioids, I mean, that's your prerogative, but can you really call yourself a pain doctor? That would be the challenge I have for those physicians because, yes, opioids are not the most perfect drug, but they do work for a lot of people. Not everybody. A lot of people, they've worked for 1,000 years, 2,000 years, and they're going to be around forevermore, and so if it is appropriate for that patient and you can document and make that argument, then it might be appropriate for you to prescribe it. But if you're just blanket stating, I'm not going to do that, again, can you call yourself a pain doctor? And, again, that's what leads to articles like this, where they talk about, what should be a good thing, multidisciplinary, multimodal care. Now it's too often functioning as a euphemism for pharmacologic exclusion. And again, come on. Behavioral and other modalities are not simply added as supplemental support. They are increasingly used to displace pharmacologic care entirely. And when they fail, as too much is often being asked of these supplemental modalities, the institution retreats into the cowardly posture of abandoning further recourse and condemning the patient to unnecessary suffering under the veil of exhausted options. And yeah, wow. I mean, clearly this guy's a writer. He knows how to put words together, and that hits hard, right? As a pain doctor, that hits hard. Because again, I see this happening. And, I think I would put a lot of blame on insurance, to be honest with you. A lot of, come on, we can always blame insurance for everything. But a lot of the challenge to even getting an MRI, right? Like a patient could have back pain for 6 months and come in to see me. And, the appropriate thing to do in that moment that I would decide, let's say, is get an MRI. But then the insurance will come back, well, did you do, 3 weeks of physical therapy first? I'm like, look, man, if the pain was there for like 2 weeks, okay, let's do some PT. But the patient's had this for 6 months. Like, that's a little concerning. There could be some other things going on there, I want to make sure that they're going to be safe candidates for rehab even, But insurance so often requires, let's say, physical therapy to be done first and foremost before anything else should be tried. And I find two problems with that. Number one is that my pain textbook itself that I learned and studied from in fellowship admits that physical therapy, while it can help pain, its primary purpose actually is to improve or maintain function. Okay, great. I mean, I'm not, downing the purpose of PT. That's great. That's what we want. We want to keep up and moving, but that's the primary purpose. The expectation is not pain relief. If you get pain relief from physical therapy, that's an added bonus. Okay, this is in the pain medicine textbook. This is what the studies support. Okay, so, but the problem is we've ingrained it so strongly into our culture and our treatment plans. It's like, well, let's try this first. When it fails, I'm telling you, every pain doctor out there that prescribes physical therapy expects it to fail. So, I'm painting with a broad brush. There's certain conditions that I expect it to work very kindly for, but the average chronic low back pain, is it really going to do much good? If you're overweight, yes, we could make some arguments there. But again, I'm painting with a broad brush. Most doctors check the box for PT because they expect to come back and do a procedure. And they're checking the boxes for insurance. But again, it's this type of behavior that, really, I think, it ruins the reputation for PT. It ruins the reputation for multidisciplinary care. It ruins the reputation for conservative approaches really in general. Because if we're just doing it to check a box, we're not, uniquely applying certain treatment protocols for certain patients, then what are we doing? You're going to get mass failures. It's going to create reputations for itself, and it leads to arguments like this. But it gives doctors and therapists and everybody something to do other than write the medications, really. And not to say that this whole approach is to, push opioids for everybody. I've said this before, I'm neither pro-opioid or anti-opioid. I am pro-pain control. That's my primary role. And I see opioids as a potential tool for the right person, right? Just the same way I see NSAIDs the right tool or physical therapy the right tool. But what this article is making the point is that that's not how society sees it. And that's the problem. It's a double standard. So I like what he said here. It is systemic therapeutic narrowing disguised as fashionable sophistication. Yeah. A person struggling with addiction would not typically be denied pharmacological intervention. A person with diabetes would not be denied pharmacologic intervention. A person with depression would not ordinarily be denied pharmacologic intervention. Yet, pain patients increasingly are, and most perversely, they are told it is for their own good. Yeah. And again, because it's really hard to talk about this stuff on a patient-by-patient basis, right? It's hard to do a podcast talking about a patient-by-patient basis. It's hard to write articles in the same way, right? So everybody sort of has to paint a broad brush when they're trying to make their arguments. And to be honest with you, I feel like that's really important for this topic. I don't think that we're ever going to have a resolution on it. And that may not be what you want to hear, but that might also be for everybody's own good to some extent. I mean, think about it. If you took away the regulations, you would have pill mills overnight. 100% guaranteed. How do I know? Well, we've been there, even with mild regulations, right? And it just goes to my point that is where the money is being made. And every Tom, Dick, and Harry patient and any doctor that wants to pay off his student loans and then some is going to do quite well under that structure with no regulation, right? So I think you do need some regulation. The problem is you're going to have undertreatment. It's going to inevitably lead to undertreatment. So then you have that group of people who are arguing back. And so it's almost like, you have two people fighting in a lifeboat, and it just so happens that, the way they're rocking the boat is keeping it afloat. It's just moving with the waves. And it's like a tug of war it's keeping the flag right in the middle, and that's sort of almost where we need it, right? And I know already there's going to be folks on this side of the fence who are going to not like that opinion, and there's going to be folks on the other side that are not going to like that opinion. But I don't know, chalk it up to my personality type. I'm a middle of the road kind of guy. There almost needs to be some tension in this topic because, yes, they make the argument that, well, yeah, somebody who has depression would need medication. Someone who has diabetes would need medication. Yes, of course. But it's not quite the same because those medications really don't have any street value, right? There's really no possibility for secondary gain, right? That's the problem with pain. In a lot of ways, pain itself is subjective. We don't have an objective measurement. We can't compare it to cancer where we can see it on a lab result or see it on an image and we can cut it out, or we can get a new lab result and say you are cured or you're not, right? Unfortunately, pain is wrought with the potential for secondary gain, whether it's just having pain itself and the potential monetary gain you can get from that, or having medication that maybe you don't need, but the cash would be a little bit nicer, right? So I'm not pointing fingers or, calling people out. That's not the point of what I'm trying to do. The point is that it's really not the same. And as long as we've had opioids that have cured chronic pain, we've had problems with opioids. We've had, governments that needed to feel like they needed to crack down. And this medication's even led to wars, and so it's not exactly the same as, well, how come we just can't give them insulin? How come we just can't give them blood pressure? No, it's unique. Opioids are unique. And so they do require sort of a nuanced approach, a respect, certainly. And what I like about articles like this is it sort of pulls the rope away from overregulation. And you can make the argument that we're overregulated. I'm not saying, our regulation is perfect right now. You can definitely make the argument that we're overregulated. Like, do I like the idea of being inspected, on a semi-routine basis, with the idea that, I'm guilty until proven innocent? Nobody says that, but that's the feeling, If I can't produce a certain document that they requested because, healthcare has exploded into 1,000 documents per day per patient, right? Like, is it right for me, who is really trying to do everything the best way I possibly can, to lose sleep at night wondering if the state's going to increase their investigation or even shut me down after all the work that I've gone through? No, I don't think that's right either. But again, that's the overregulation. So I like articles like this because I feel like it pulls it back, or at least attempts to pull it back, or gives some, additional perspective to the conversation. Although I don't necessarily, agree with everything in the article, because if we were to go completely the opposite, we would just have a different set of problems. What I do like this, though, is that institutions, he goes on to say, institutions become self-congratulatory for moving beyond so-called biomedical models, for emphasizing function or relief, and for reducing reliance on medications deemed politically and morally dangerous. Yeah, and I've called that out before. Man, it's like a badge of honor. Institutions, doctors that work for institutions, again, nothing against these folks. They're good people. They mean well. They're highly educated, and they treat their patients well. Okay, I'm not calling them out for that. But there is a culture in these bigger institutions that elevate their existence above opioids, almost as if they've never needed them themselves, right? And again, that's not the practice of medicine from my perspective. That is an agenda-driven business at that point. And as a patient, if you happen to benefit from their agenda-driven business, great. But a lot of patients don't fit nice and neat into their treatment protocols, or even have conditions that would benefit from their nice and neat treatment protocols. But they're still not in a position to write certain medications. So again, it's like, well, are you in the business of treating patients, or are you not? And I 100% agree with that. That is, it's kind of sad. This allows them, going back to that concept, this allows them to preserve public prestige, avoid regulatory scrutiny, and align themselves with the dominant moral narrative of the post-opioid era, all while claiming to practice restraint and responsibility. Prudence is not a virtue when it becomes a pretext for abandonment and unnecessary suffering. True. Responsibility is not a virtue when it is weaponized against what is arguably one of the most stigmatized patient populations and one of the most moralized forms of suffering. In this grotesque caricature of the art and science of medicine, institutional self-protection and prestige cynically masquerade as patient care. Yeah. Now, responsibility is a virtue. Who defines whether it's being weaponized or not? I mean, that's always a question too, because there are some patients that should never touch an opioid. I mean, let's be honest. And to the same extent, there are some doctors that should never prescribe an opioid, okay? So I think what I'm going to, the meaning I'm going to overlay on that is sort of what we've already been talking about, right? Like the arbitrary denial of what would be an appropriate prescription, like through high ACE scores, right? And we've talked about that. Or other things where it's like, well, you lost your medication one time because you were in the hospital and you had this other thing going on, and now, we're cutting you off. It's like, okay, but understand there's like some details to that story. It's not like, this is a pattern. It's not like, have some understanding, right? But a lot of physicians just don't want to write opioids, and they will use whatever excuse they can come up with. That, I think, is what is being weaponized. And yes, we've talked about that a lot. So the article concludes, what is the solution to all of this? It needs a serious return. We need a serious return to scientific as well as humane standards. And again, I would sort of argue back, if we're going to just stick with what the science shows, then probably most people would not get opioids long term, right? And I think that's often misunderstood as well. It's not like all these physicians are not practicing good science. The science actually does not really support long-term opioid use. And I know, again, many of you are going to want to argue that, and that's fine. We can have that discussion. Many of you may just disagree or what have you. But as far as I know, man, the long-term studies on the benefits of opioid use is minimal at best. And the potential for harm or poor outcomes is high relative to the benefit for long-term use. Now, these studies, they're broad studies. They're looking at, lots of different types of patients. And if I've driven this home before, 1,000,000 times, I'll drive it home again. It all comes down to individualized care, right? It comes down to the relationship you have with your doctor, the trust that you have with your doctor, and, really determining what is the best approach for you. And so, long-term opioids are not for everybody, but a lot of people need them. And it's not like nobody's getting opioids. I mean, there's like 4 to 5 million people in the US that are maintained on long-term opioids. And there's only like 2,000 pain docs. So, you can do the math on that. I think probably most long-term opioid prescriptions are being written by primary care. There's 100 million people with pain. There's 20 million people with severe enough pain to basically, totally debilitate them. So are we undertreating on some extent? Probably. We probably are undertreating. I will stake my claim on that opinion. But again, the evidence is weak when we look at broad numbers. So, this can be a whole nother video, like what am I looking for, right, for a patient that might be a good candidate? The average person on a long-term opioid therapy is like 60. Most are above the age of 55. So probably 40, 50, maybe even 60% are above the age of 55. And that stands to reason. Younger folks who might need opioids, it's a little bit more challenging because even if I approach a younger patient who's really tried everything, right? I mean, I have these patients not uncommonly. They, I'm talking like 30, 40-year-old patients who've tried every injection, tried every therapy, tried every medication. They're already on like 20 medications, and they're still here, like something's not quite, cutting it, and they're still quite debilitated from their condition. And a lot of times this is not a focal area of pain. It's not like I can just do a nerve block. It's not like I can just put in a stimulator, right? Or do a surgery and call it a day. These are very severe, centralized, in many cases, pain conditions, and our options are limited. Even in those cases, I will try to, go very slow with the opioids, because in my head, I'm like, okay, well, how am I going to manage you for the next 30 years, 40 years, 50 years, right? Especially the younger you are, the brain adapts, it's neuroplastic, your tolerance builds very quickly. And so we climb that opioid dose ladder very quickly. And then, eventually that ladder has a top rung, right? And you could be in the same amount of pain at that level than you were at a much lower level, but now we have the liability of all this medication. Keeping track of it, making sure nobody takes it. Of course, all the side effects, right? I mean, it's been well documented that long-term opioid therapy will destroy your hormonal system, increase your chance of high blood pressure, cholesterol, diabetes, obesity, right? We don't think about stuff like that in most cases. Constipation and all the complications that go along with that. And it's even associated with earlier onset dementia, right? And especially the younger you start taking it and the longer you end up taking it. So, it's not a great medicine. And so we're weighing all of these things into the equation when we decide to initiate a patient on it. And again, it's not to say that for one particular patient, the benefits don't outweigh the risks. That can certainly happen, but it doesn't mean that there's no risks. And as a pain doctor who's taking those risks, it is upon me to bear that responsibility as much as I feel like I can defend, right? I mean, oncologists take that risk all the time. They give patients new and experimental medications, and a lot of times their patients don't survive. Now, could it be due to the medication? Could it be due to the primary disease process itself, or certainly a combination of both, right? So, the difference from their perspective is that, well, if I don't intervene, the patient may not survive anyway. True. But why can't we say the same thing for pain management? Is that not the same thing? Perhaps the mortality rate is not as high, but untreated pain has some significant consequences. And so, weighing all of that again into the equation is extremely important. Let me know what you think. This has been a very interesting episode, at least from my perspective. Great article by Joshua Saylor. Again, certainly brings to light a lot of the tug of war that we experience, both as doctors and patients, I'm sure. And so, again, through this channel and episode and our mission, we want to bring these things to light. We want to open up that conversation and do what we can in order to help you live more with less pain. Until next time, I am Dr. Dustin. Take care.